So we are about to start the next session, which actually is exactly in line from the previous session. This time it's a session on simulation and bench testing. And what we'll do here again is to see what is upcoming, see what is new, and have a discussion. But I think to focus the discussion, we will actually choose to have the discussion of all the presentations in the end, so we can actually summarize everything. So please, when you have questions, remember them, write them down, and we'll actually address them in the end. But very welcome to the session. And as the first speaker, I would like to introduce Nicolas Amabile to give us a talk on the analysis of longitudinal stent deformation by 3D technology in an in vitro pilot study. But I can't really. We haven't seen him here. Okay, maybe is it possible that we could shift to the pre-recorded presentation by Susann Beier, which would be the next one? Yeah, because then I will actually introduce that, and then we can put Nicolas in the row when he arrives. So, it's a great pleasure to introduce Susann Beier, which has been a participant in the club for many years. She's based in Australia at the moment, but her talk will be pre-recorded and will discuss our ultra-thin stent optimal for bifurcation lesions, insight from computational simulation of provisional and decay cross techniques. So again, down to techniques based on simulations. So please just let the talk run when ready.
Everybody, it's my great pleasure to present to you again here at this wonderful meeting. My name is Associate Professor Susann Beier, and today I'll be talking about the question if ultra-thin stents are optimal for bifurcation lesion stenting. We use computational modeling to provide new insights for provisional as well as TK crush techniques. I'm presenting on behalf of many wonderful co-authors listed here today. So let's jump right into it. We, as mentioned, looked at the provisional side branch stenting, which is the default for most bifurcation lesion stenting. We compared it to DK crush, which is commonly used for complex lesions, which can be technically demanding. Now, the question is, in both these settings, are ultra-thin stents, the new emerging stent platforms, are they suitable? And we therefore analyzed and compared a thin strut, meaning less than 100 microns, to an ultra-thin strut, meaning less than 17 microns in both these scenarios. We decided on the Osiro helical-based ultra-thin stent, which is 60 microns strut thickness, compared to the Sciencera ring-based stent with 18 micron strut thickness. I also like to point out that for the nominal bifurcation we used, these are the manufacturer's standard sizing respective for the bifurcations. You can see here that they slightly for the main branch as well as the side branch, and I circle back to that a little later. Now, our computational model of the side branch stenting steps are shown here. You can see each of the individual steps whereby the type vessel lesion bifurcation is deformed throughout the course of the stent deployment with different balloon steps. This compared to the DK crush technique, where we start with the side branch stent, have two stents obviously deployed over the course of many different stent deployment and sizing adjustments, as you're all familiar with. including the first kissing balloon inflation, again here now implanting the main vessel stent, and then followed by pot. Another second kissing balloon, and the final pot, as you can see here. Now, what did we look at? We analyzed different clinically relevant endpoints, including malapposition linked to thrombosis and restenosis. We looked at the side branch osteum clearance linked to late-stage thrombosis, arterial wall stresses, which promotes restenosis and arterial injury, as well as endothelial shear stresses, so blood flow related metrics, which promotes inflammation and neointimal hyperplasia. Starting with the malapposition, we looked at first the provisional side branch. You can see in the top row is the result for the Ozyro, and the bottom row is the Science-Sierra stent. The malapposition rates, so the malapose struts are shown in red, and you can see that there were slightly more malapose struts in the Ozyro stent scenario versus the Science-Sierra with 3% difference. If we look at the same for the double kissing crush, you can see that the trend continued. So Ozyro had larger rates of malapose, so non-opposed struts over the whole stented region, with differences across the side branch as well as the main branch. What we can draw from that is that Science-Sierra overall provided better scaffolding scenarios for both techniques. Now, moving on to the side branch clearance, linked to late stent thrombosis, as mentioned previously. First, looking at the results of the side branch, again, we can see with the yellow background, the osteum clearance in percentage. So Ozyro had a 77% osteum clearance compared to the Science-Sierra with 64% clearance. So much better clearance for the Ozyro. However, we also noticed that the Ozyro generated an oval shape of which can be measured up to 13% versus a Science-Sierra with a much more favorable circular osteum shape in the end. For the double kissing crush, the osteum clearance became the difference were minimized. However, the oval shape in the Ozyro stayed. Now, what we can draw from that is that for a provisional side branch technique, the Ozyro overall performs better, likely due to its better flexibility. However, overall, it generated a more ovalized osteum, which is not favorable. Moving on to the arterial wall stresses, so the stresses imposed within the tissue, we can see that for the provisional, Ozyro generated much higher peak stresses, but overall had a slightly smaller area affected of adverse arterial stress. For the double kissing crush, any differences were pretty much eradicated in the double kissing crush scenario. What that means is that technique is a main driver of wall stress and restenosis. So, and that the platform, the stent platforms for the double kissing crush doesn't matter so much. And Ozyro introducing higher wall stresses. Now, in terms of hemodynamic profile, so the stresses imposed on the endothelium promoting inflammation and neointimal hyperplasia, we can see that for the Ozyro, we had 30% adverse areas linked to adverse clinical outcomes versus 34%. So small differences, but in this case, Science-Sierra was worse, so larger adverse areas were found for the science sera. This continued with the technique where we had the double kissing crush had even larger unfavorable areas for the science sera, meaning that Osyro with its thinner struts is more favorable in generating favorable hemodynamic flow profiles despite its longer length, what I mentioned earlier in the introduction when I introduced both stent profiles. And so generating better hemodynamics and less adverse effects on the endothelium. Now, in conclusion, for the provisional side branch stenting, the device choice matters. Overall, we can conclude that the science sera suits more calcified lesions, wider bifurcations, and larger vessels. The Osyro, on the other hand, would be favorable for smaller vessels, long lesions, or even diabetic patients because of its higher flexibility and larger, better hemodynamic profile, which is more prominent in smaller vessels. By the same token, for the DK crush technique, many of these differences were overruled, meaning that the outcomes dependent on the execution rather than the stent design, with only very modest hemodynamic benefits for the Osyro. Now, overall, what we can draw from this, the very first computational modeling of a DK crush, which our team achieved as a first worldwide, is that the stent choice and the technique matters, and it should be considered together, whereby anatomy and procedure mutually can influence the results. So thank you again to the great team. A few of the collaborators are able to attend this meeting in person this year. I believe Nigel is there, Claudio's there. And I also like to highlight Andrea, the PhD student who was leading this work. Thank you so much for your kind attention. Thank you.
Thank you very much to that video presentation. If you have questions, we just take them at the end of the other presentations. So we will move on with the next presenter, which will be Anass Maaroufi, who will talk about perforation management in the setting of bifurcation PCI bench test analysis.
Yes.
Okay, next one.
Hello, everyone. It's a great pleasure for me to be with you today in order to present the results of our bench testing involving perforation management in the setting of bifurcation PCI. So we know, all of us, that the more are we dealing with complex lesion and calcified lesion, sooner or later we're gonna stumble upon complication, and one of these complications involves perforation. So it's a life-threatening complication that needs to be dealt with in a very fast pace, and in that sense, if it happens in the setting of a bifurcation, it's more challenging. So we can deal with this perforation either with balloon prolonged inflation, which means like balloon tamponade, or sometimes when it doesn't manage to seal the perforation, then we are more prone to put a cover stent. However, in the level of a bifurcation, putting a cover stent, that means that we need to deal with collateral damage, which means a jailed side branch, and in that sense, it could be accepted as a collateral damage. On the other hand, if the myocardium, who is supplied by this jailed branch, is substantial, then we need to gain access to this jailed branch in order to improve outcome. So this is where the idea about our bench test comes from, how to regain access to our jailed branch. So in order to perform our bench testing, we use 3D printed silicon bifurcation models, And first, we started by the selection of the wire, which wires are capable of crossing the covered stent towards the side branch. So we use a wire escalation from a tip load of 1 gram to 14 gram with the support of 120 angulated microcatheter. So the success to cross the covered stents means that we managed to puncture or fenestrate with the microcatheter, but also the tip should not be damaged and the microcatheter should be able to follow up, and all of that should be under 5 minutes, which is an arbitrary cutoff that we decided to do. Because anyhow, we are dealing with the perforation and we don't need that to take long. So we tested multiple scenarios. In the first one, in case of a perforation that's taken place in the polygon of confluence, so this is the provisional stenting using a cover stent from the distal main branch towards the proximal main branch, then reacts to a side branch and perform a kissing balloon inflation. Second scenario is to add up DES in the side branch. A third combination would be to do a double culotte cover stent in the main branch and the side branch. And the fourth combination would be to add up a DES in the main branch. All the procedure was guided using OCTs in order also to evaluate the result in terms of lumen area reduction, but also about the fenestration and the hanging material. And that will be correlated to the angioscopic analysis about the understanding the mechanism about this lumen area reduction. So what about the results in terms of wire? Which wire succeeded our test? So the wire that has been tested from Fielder XCA to Infratract Plus. So any wire that has a tip load from 12 gram and above managed to pass the test in duration of attempt less than 1 minute without damaging the tip or failure of the microcatheter to cross. In terms of lumen reduction evaluated by OCT, in case of crossover stenting with the cover stent, we observed that we had a 25% of lumen reduction towards the side branch, which could be corrected if we put a DES in the side branch. On the other hand, if we put two cover stents in a culotte fashion, we have these numbers that could be moreover improved if we put a DES in the main branch. So why we have this lumen reduction, actually, once we fenestrate the cover stent, we could have a hanging material towards the side branch. So this is what we can see in figure A, which is at the level of the osseum of the side branch, which could be sealed and pushed away once we used a side branch DES. And the same goes when we use a double covered stent. We could have this hanging material working as a diaphragm towards the osseum of the distal main branch that could be pushed away again using a DES in the main branch. So the same image, we can see them better using angioscopy. So for the same sake, we can see these overhanging meshes hanging around that could be easily pushed away using DES. So for further illustration, so this is the crossover cover stent in the main branch, and we can see this overhanging material at the level of the side branch, which we managed to get rid of, using a culotte conversion, adding a DES in the side branch. So as a conclusion, cover stents could be done in bifurcation, but when the ischemia is driven by jail in a side branch, we need to reaccess to the side branch, which can be used by any wire that has a tip load over 12 gram. Provisional stenting and kissing balloon inflation deliver good outcomes, but with the downside of having overhanging material that could be overcome by a conversion to culotte using DES. And we know the limitation of bench testing about like how it could be applied in real life, but we still can propose the type of algorithm that's in terms of dealing with perforation and polygon of confluence. We could cross over stenting, perform our part wire penetration and kissing balloon inflation, and then we evaluate in geographically if it's still perforation has been sealed or not. If it has been sealed, then we can evaluate using OCD towards the side branch and the main branch with more focus on the side branch. And in case of overhanging material, then we need to consider equilates using a DES in the side branch. On the other hand, if we don't manage to seal the perforation, we can add up a covered stent in the side branch and recross again using equilate fashion and consider again OCT for the overhanging material and complete with another DS in the main branch in case of overhanging material. And thank you.
Thank you very much. And please stay in the room for further stay in the room for discussion later on. And the next speaker will be Nicolas Amabile. Welcome, Nicolas. Analysis of longitudinal stent deformation by 3D technology and in vitro pilot study, which will actually show us how you go from bench to simulations and back.
Thank you very much, Jens. Good afternoon, everybody. I apologize for my delay. As you know, the longitudinal stent deformation is a classical pitfall of proximal right coronary artery and left main PCI. It's mostly underdiagnosed by conventional means, but when you try to study that with intracoronary imaging, you observe that the incidence could be up to 20% in left main, as shown in the October trial. The issue is that when this stent deformation is remained untreated, it negatively impacts the clinical outcome as it was shown in the Excel trial. And so it's very important to be able to identify the LSD into the cath lab. So the aim of this in vitro pilot study was to test the performance of a new 3D stent imaging mode created by GE Healthcare for the diagnosis of LSD. 3D stent is an X-ray based method that is related on rotational angiography acquisition at 30 images per second during 30 seconds around the patient. The images, these high quality images, are then treated by some motion compensated 3D reconstruction software that allowed us to get this image that you can see on the left, on the right panel, with a 3D reconstruction of the structure of the stent that you can analyze in different planes and cross sections. For this study, we decided to create implantation of 41 stents into silicone tubes into two groups. The first group was a regular implantation without any compression. The second group was an implantation of this stent into the silicone tube, and some longitudinal compression was created with some dedicated maneuvers that you will see. Then after, all the samples were analyzed by X-ray, and 3D stent reconstruction plus multiple stent vis acquisition were performed. All the images were analyzed by 3 independent blinded reviewers with 3 rounds of analyses in random sequences. That's how we created the LSD in vitro. You see, it's not rocket science. We implanted the stent into the silicone tube, inflated it, and then we pushed the balloon slightly over the stent, re-expanded, and then pushed on the guiding catheter to create this compression that you can see on panel F. And it's, I hope that it's not the kind of things that we can do in the cath lab, but for the purpose of this in vitro trial, we really create to exaggerate the pitfall. All the samples were then acquired, get the X-ray acquisition in the cath lab. As you can see, this is a rotational angiography, And you can see some examples of reconstruction of non-compressed versus compressed stent. And as you can see, the difference appears to be quite obvious. We created 5 criteria to analyze the structure of our stent. We were looking for the presence of an increased radial opacity in the proximal stent section, the loss of the stent border parallelism, the loss of the stent cell symmetry in the proximal part of the stent, decreased stent length as compared to the initial stent length. And at last but not least, we measured the internal stent area on the cross section and tried to observe a decrease in the internal stent area of the proximal edge of the stent compared to the distal part of the stent, and a 15% decrease was considered as significant. This slide shows you the overall performance of the 3D stent for LSD identification based on all the 246 images that were analyzed for this trial. You see that the sensitivity of the technique to detect the compression was 99% and the specificity was 100%, with a predictive positive value of 100% and negative predictive value of 99.2%, which was very, very good. We observed that the intra and inter-observer variability for the overall diagnosis was quite good, and in all cases it was over 0.9. We also analyzed the individual items' performance for LSD identification, and once again we observed that each item has a pretty good sensitivity and specificity for the detection of LSD. And once again, the inter and intra-observer performance variability for each item was quite acceptable overall. We also created this LSD score analysis that was the sum of each item based from ranging from 0 to 5, and of course we observed that the stent with LSD got a much higher score, and the ROC curve was also quite good, except that I'm not sure that with this size, the shape of curve, it's so relevant. However, the 3D stent imaging technology appeared to be efficient to identify LSD in vitro, and the analysis based on the different pre-identified items appears reproducible and accurate in vitro once again. Whether these results could be translated in vivo needs to be assessed in future cases, and I propose you for the last minute of the presentation to go over 2 examples that were acquired in vivo in our CAF lab in ECPS. The first one is a nostril left main PCI in a patient with a previous left main stent on the distal part of its vessel. It was a quite straightforward procedure with some preparation with non-compliant balloon predilation, implantation of a 4.0 megatron synergy stent, and final pot on the very proximal part of the vessel with a 4.5 non-compliant balloon, with a quite good final angio result. And this is a kind of image that you can observe in vivo. So this is the 3D view. You can really see the short megatron position into the proximal part of the vessel. You can also see some calcium surrounding this stent. You see the previous stent that was from the distal left main to the proximal AD. And I was pleased to see that the structure of our stent was still okay. There was no shortening, no decrease in the internal lumen, despite the very short distance between the guiding catheter and the stent. But you can also see that there was a geographical miss between the distal edge of the new stent and the previous stent. With the technique, you are also able to measure the cross section and get a glimpse of the expansion, and in this case the minimal stent area was measured at 12.8 square millimeters, which is quite acceptable for a 4.0 stent. The final result, and let me just translate to case number 2, which is a distal left main to proximal AD stent. I was not feeling confident enough to nail the osteum, and I preferred to go for a crossover, and it's very classical crossover provisional one stent technique. This is the final angio, the final stent view, but it's only in one plane. So once again, you can analyze the stent with the 3D stent in different dimension, and you nicely see the differences in stent diameter and expansion between the distal left main and the proximal AD. Thank you very much for your attention.
Thank you very much, Nicolas, for an excellent presentation on how to elucidate those complications in much more detail. We'll come back to the discussion later on. So let's move on with the next presentation, which will be on the crosstalk of serial and parallel stenosis in bifurcation lesions. Again, and this is a simulation of what happens when we remove one stenosis on the signal decay of FFR with the other stenosis. Tinen Iles.
Thank you. Thank you so much for the invitation. I am going to discuss the crosstalk of serial and parallel stenosis and how we can bring in simulation to better understand the signal decay. So first of all, I'd just like to talk about the clinical challenges of treating serial and parallel lesions and just multiple lesions in general related to bifurcation lesions, and what computational methods that we can use for simulating FFR. And I'll talk a little bit about also IFR and wall shear stress, a few other measurements, but mostly focusing today on FFR. And the results from our simulations and some of the applications that we have and next steps. So we use FFR as a decision-making tool for FFR above 80 that the guidelines suggest that we treat the lesion. And so this is, here we have an illustration of in the clinic what you might be doing in terms of looking at that pressure drop in between the lesions. And the problem being is that when there's serial lesions, bifurcation lesions, multiple lesions, is that we can't actually isolate the lesions individually to determine what the actual FFR is. So here's the problem, right, is that you wouldn't be stenting the proximal lesion first, and so inherently that is interfering with the pressure drop from that distal lesion. So what is the actual FFR of the distal lesion? There's no real way to tell. And there has been a lot of research and work in this area and different imaging modalities, but it still lacks the ability for us to make the clinical decisions. And I know I'm speaking to the choir here, but as we know from EBC main and other clinical evidence, is that overall less stent has better outcomes, and that is in terms of less reintervention, stent thrombosis, restenosis. And so what can we do to inform the operator to help support the clinical decisions? And so these kinds of questions are which lesion to treat first, which lesion needs stenting, and what techniques or combination of techniques is going to be optimal for these patients. And then I'm going to get into how we can use that by identifying signal decay. And this is taking offset from some of the consensus documentation from the EBC. This is the central illustration from looking at complex cases. But what I'd like to suggest here is that how we can be using these results from FFR and other computational methods to help to identify pitfalls, and then moving through that cycle, the pitfall in better troubleshooting and prevention for reintervention. So this is what we're actually doing high performance computing. So maybe if you joined in the last session talking about patient-specific modeling, this is not that what we're doing here. So we are actually doing really high level computational models that can give us really, really high detail. And this is in collaboration with the Barcelona Supercomputing Center, the EBC, University of Minnesota Department of Surgery, where I'm a professor, and also the University of Southern Denmark. So, and this is a non-patient specific. So we're actually just looking at anatomy and numbers and trying to identify a full cardiac cycle. But it is very detailed. So this is we created a synthetic model simulating 25% stenosis, 50% stenosis, 75%, and looking at that as a plaque burden, and coding within that having the compliance of the structures and the coronary. And this was used using Alia Red, which is a high-performance computer at the BSC. It's a in-house finite element simulation tool. And it is actually, like, I know it may look like a very simple structure here, but this takes a lot of time and highly computational. So you're actually identifying the aortic pressure here and the closure of the aortic valve and that effect on the pressures within the main branch. And so this is the LAD. So we've identified this is a synthetic LAD with two stenosis in the main branch, combination of stenosis within the main branch, proximal distal, and also in the side branch. And so we identified through these simulations, I'll show you the methods next, is how we are looking for hemodynamic markers like wall shear stress, FFR, IFR, and also vorticity was also analyzed. So this is our baseline. And so first, we just want to understand the baseline of what's happening computationally, and also looking at the Q criterion, which allows us to then calculate FFR, but on its own, it's actually very helpful to understand that in terms of the vorticity within the vasculature. And then then we ran our simulation. So this is a simulation of the left main and two serial lesions with proximal and distal. And so you can see we're running through this is a full cardiac cycle that we're running through. But I'd like to kind of pay attention here too that what we're actually doing is we're capturing the FFR from the proximal lesion. So where those two yellow dots are, we are calculating the pressure drop in between the lesion there at that point, and then with a 50% stenosis, and then also calculating the FFR in the distal lesion with a 75% stenosis. And this is just an example. We've done this with many different combinations to better understand what that signal decay looks like. And so clinically, or really we can't, you can't look to try to see what's going to happen if you stent, what's going to happen to the FFR distally. So what we've done is we've theoretically stented the proximal lesion and then identifying what the new fractional flow reserve is of that distal lesion. And so by that, we can inherently calculate the signal decay. And so this helps, so this isn't something that we would be doing in a patient-specific way. This helps us to come up with a heat map, come up with a function to better understand how the lesions are interacting with each other and causing these disturbances. And I'll also note too that we calculated this based on focal lesions, and fully aware that there's many other areas and lesions and structures that we can move forward in trying as well. So the computational simulation was based on the Medina classification, and we went through the series of Medina classifications and ran these simulations with varying degrees of stenosis. And this is actually, we did wall shear stress as well within the simulation, and so this is an illustration of that because I don't have a video of all of the simulations. So here we tested that, and then we were able to calculate the signal decay, or that lesion interference. So first we took the FFR. We also did this with IFR, but took the FFR from the case, and then we basically divided that by the FFR from the base. And so on the right-hand side, or on your, I guess your right-hand side, looking at the indices of that. So the positive percentage indices, that's the pressure decay is higher because the marker in the decrease thus worsens that, and the negative percentages indicates that decay of the pressure across the vessel is smaller, therefore increased by the percentage of that change. So I'd like to just to highlight that these are big changes. So in this example where we have the proximal main branch of 50% stenosis and the distal main branch of 75% stenosis, there's huge percentage changes in that decay of the signal. And so that just right there highlights the importance of better understanding how that might contribute to the decision-making for the side branch vessels, or possibly provisional or other techniques that you may be using. So this is just another concept here of how we can computationally, to gather this data, to computationally input back into the consensus documentation or other documentation to help to inform or identify possible pitfalls, and specifically, in this case, to better understand the signal decay and interference between the vessels. So in conclusion, in procedural planning, knowing how treating one stenosis will impact the signal decay of the other is critical, and understanding how multiple lesions interfere with each other and effective IFR, FFR measurements to help guide clinical decisions. And other computational methods can support this by creating different treatment scenarios. So we can come up with different treatment scenarios where you treat the side branch first, or which provisional pathway, if you're going the provisional pathway, or if you just have two serial lesions, you can understand the optimal order. And so continue to work on further support of decision tools, and then also incorporating clinical data to support this as well. So thank you so much for having me. Really appreciate the time. And
Thank you very much. And again, please stay for the discussion afterwards. We will move on with the next presentation, Francesco, stepwise provisional in left main trifurcations in a bench test study. And again, the technical challenges increases, and we learned a lot from the bench. Right, Francesco?
Okay. I'm presenting here on behalf of Gabor Toth, that is co-PI, and all the tribe investigators. The aims of this study were starting with the perception that coronary trifurcations are quite common and are known to pose major challenges in the case of PCI with drug-eluting stent implantation. We designed a bench test study to assess the impact of technical manipulation on the final geometry of a last generation drug-eluting stent. This is the model we applied. It is a large left main, 5 mm, with the LAD 3.5, Ramus 3.0, and LCRX 3.0. This has been selected with the angulations that are taken from a library of CT scan published in the past. So this 3D printed silicon trifurcation model has been used, and this is the environment where we performed the PCI inside the Gemelli Training Center, where we have been able to host the two teams from Graz and Rome. And the stent that has been tested is the Altimaster Nagomi. We tested 4 variants of the provisional stenting, and we will see 2 different rewiring techniques and 2 different ballooning techniques. 3 couples of expert PCI operators performed each variant, 12 total tests. The procedures were performed under visual control. However, OCT was used for rewiring spot check, like in the October trial, and the final result assessment. And micro-CT was performed after the test offline by operators blinded to the procedure. What we did was crossover stent with the drug-eluting stent size according to the distal main vessel reference, and then the POT. And I should underline the fact that for Nagomi, this is on label, because the 3.5 platform may allocate very well this POT balloon. Thereafter, the different scenario were these. First scenario was rewiring of the 2 side cells in different cells, so rewiring through the two side branches through different cells, and tracing balloon inflation. This is neighbor cell. The first rewiring was very distal, and the second was in the second cell proximal. Scenario 2 was to rewire both wires into the distal cell, aiming to achieve, however, the rewiring of the two branches and tracing balloon inflation, and this is same cell rewiring plus tracing. Then we tested the possibility to have neighbor cell rewiring, so two different cells, and sequential kissing. That is something that we can use in the case that we have in the practice to deal with the trifurcation. Done like that, so first kissing with the LAD and ramus, and second LAD and circumflex. And this is called serial kissing. And the fourth scenario was rewiring through same cell, distal cell, and then same sequence of serial kissing. So then we performed the OCT analysis to assess the stent expansion at different spots, left main, POT, and LAD, so the stented area, and stent malapposition. We selected a measured malapposition more than 200 microns at 3 millimeters distal left main, POC, and LAD. And then we performed also micro-CT analysis. Again, it was done on blind, and we assessed the MSA at proximal main vessel, POC, and distal main vessel in the LAD. And we also assessed the minimal stent cell opening area at the level of the circumflex and ramus ostia. The overall stent expansion by both OCT and micro-CT was very, very nice. This means that the stent expansion is satisfactory across all stented area, with all segments having more than 80% stent expansion. So this means that with last generation drug-eluting stent, in a trifurcation model where there is a significant step up, it is possible to have with all this technique a very good expansion of the stent. When we go into the stent expansion observed by different techniques, there is the splitting according to the site of rewiring and the tracing or serial kissing inflation. I will not enter inside, but there is no significant difference. So this means that rewiring and ballooning technique does not affect the overall stent expansion by OCT. When we went with micro-CT, I mean, the precision of the measurements increases a little bit. So we have been able to find some really minor signals. The only minor signals we have been to see is the fact that we had a larger MSA at LAD with the same cell rewiring by micro-CT, but you look at the difference is very marginal. And regarding the difference in ballooning, we found that there is larger MSA at the polygon of confluence with tracing. This is really expected because, I mean, if you have 3 balloons inflated in the polygon of confluence, you will stretch more the stent struts. Regarding the OCT stent apposition, what we found is that the measured malapposition was encountered sometimes only in the polygon of confluence and was not influenced by the technique. Let's imagine that at the level of the polygon of confluence, the vessel really becomes bigger, much bigger than the 5 we have in the proximal main vessel. So in that area, it is possible that there are some struts that are malapposed. But I think that the most important aspect came from the micro-CT stent self-fenestration assessment. You see that with the same cell rewiring, we have a single stent cell opening area in which the average was 16.4 millimeters. This is the reconstruction allowing you to understand what we are dealing. So if we rewire through the same distal cell, we will be able to scaffold the stent, having this big hole that gives access to the both branches. There is, as a side effect, the fact that you see that into the distality of the polygon of confluence, this is a less coverage of the vessel wall. When you compare the double rewiring in distal cells, this is the configuration we have been able to see. You have here a better understanding figure, and you see that there are definitely two different holes with some metal in between, and the mean sum of the two cells is 27.9. And if we compare these two figures, we should understand the fact that the single cell opening area is less than the sum of the two cells opening areas, okay? So it seems that the final hole you achieve here is on the left, is a little bit less, or is significantly less. But if you compare with the sum of the reference area you have for the ostium of the intermedius and circumflex, the single opening area we achieve with the same rewiring is more than the sum of the reference areas on two branches. So to recap, it seems that both of the rewiring sites, although they are associated with completely different shape in the bifurcation area, are appropriate to manage the two branches. So the conclusions of this study are that stepwise provisional conducted according to different rewiring and ballooning techniques nicely adapt to the implanted stent in the left main LAD to the complex trifurcation anatomy. Stent expansion and apposition in the left main LAD looks mainly independent from rewiring and ballooning, with some minor differences noticed in some analysis at micro-CT. But the pattern of side cells fenestration achieved by ballooning is strongly affected by the rewiring site, one or two fenestrations. I think that to know this is something important we have in mind during our interventions in the case we are dealing with large trifurcations like left main trifurcation. I have to close the presentation with special thanks. In particular, I think that the Terumo team should really reward it because they provided us the support with the devices to perform this test. In particular, Raffaella Di Prima from the Terumo team Italy was really fantastic. And also, I mean, I think that the Graz and Rome team did really a fantastic job together, and this is typical aspect that comes out from the attitude of the European bifurcation team. Thank you.
Thank you very much, Francesco, and thank you very much to all the speakers to leave us so much time for discussion in the end, because now we can turn to discussion. And I will actually start to open for the floor. If some in the audience have questions specifically to some of the presentations, please raise your hand and we will provide you with a microphone. And when you're considering your questions, I would actually turn to the panel. And well, an overarching question is, and if we just take a short comments from the end, how do you see bench testing and simulation in providing the field of PCI? We have given a lot of different perspectives on what we can learn and what we can do, and how do this translational tradition fits into our daily practice?
This is a very, very important question. I believe it has value. For example, in the work of the Susann Beier, which in my opinion was the best representative case of simulation performed, shown today, it has been clearly shown that thin strut stents improves the local hemodynamics. And this is something that we have seen also to be related with clinical outcomes. We know that in the bare metal stents especially, but also in drug-eluting stents, in specific lesions, especially small vessels, you have better prognosis because you have better hemodynamics. There are some limitations, of course. For example, it was not possible to assess embedment, which is important in the local hemodynamic forces distribution. And the other thing that we have not seen is the effect of the flow disturbances that we can see if you have malapose struts from this analysis. But you can get an insight about what you can achieve and what is the limitations of each modality. And I think we should do more to better understand what kind of results we can have with different stent platforms. And the work that she has done, it was really, really outstanding.
Thank you very much, Professor Magdy.
Yeah, I think we are doing our daily cases, bifurcation, left main. Maybe some cases are complex, some cases are simple, and now we learn from the bifurcation club that provisional stenting and one stent technique is better. However, there had been evidence that science of bifurcation and left main is very important to support what we are doing in practice. And we understand this. This is not easy. Maybe you go to bench testing, doing that in Minneapolis and with collaboration with universities to understand if we are right or not. And sometimes we are surprised that after a few years we discover that something is not that right, and we need to know that from the bench testing. Today I learned from the guy who had shown that graft stenting in left main bifurcation. It's, I mean, in this area, and then we can cross the graft stent, and then we work even in the same session after stabilizing the patient, or maybe furthermore. Also, I learned a lot from the lecture of Professor Francesco Burzotta. The trifurcation is almost 15% of our cases, and so what we need to do, maybe we can add to that the size of the maybe trifurcation, but maybe too large branches, and one is very small. Maybe you don't need to do anything; you just keep a wire. But we need to understand from all these things. My question also for the stent deformity is going to Nicolas. Is it related to the type of stents? I mean, in the past we had some claims that certain stents are liable to have this phenomena. Is it still the same, or now it happens to every stent?
No, for the in vitro test, we tested 2 platforms, and we haven't seen any difference in terms of deformability. But once again, as you saw, the maneuvers we applied to the stents were quite aggressive. So in our clinical practice, now that we use this 3D stent technique in all of our Ostia PCI, so it could be left or right coronary ostium, with 3 different platforms, we haven't seen any difference in terms of deformation. I cannot say that one platform is more prone to deformation than the others. Maybe, Francesco, you have a comment?
Yes, I think that your model, you highlighted that is very aggressive. So we can say that any kind of drug-eluting stent actually can be deformed when you are very aggressive. Probably when there is a minor interaction between the guiding catheter and the stent, it is possible that some platform is still a little bit more suitable for the longitudinal, but the model was very stressful for the
So
stent.
extending to that, if some people are intubating the guiding cath, touching the stents, this could also influence and may impact this may induce some sort of stent deformation. Certain techniques we have seen now, the bench testing, but there is any recommendation from Francesco or from you regarding how to avoid that?
And it's actually...
No, my recommendation, it's something that we're going to develop during the Boston Scientific Symposium also. First is to be aware that it can happen, because if you're expecting that, then you're maybe more attentive to identify that in the cath lab. And what I do now is in all my PCI involving any ostium, I will go at least for a floating wire. And then there was a new technique, or just an adaptation of this floating wire with a floating balloon into the aorta that can be used to prevent stent deformation. And it was published this year by a French group. So the floating balloon is for me a good way to avoid that. And at last but not least, just to, in case you have any doubt, just to largely use intracoronary imaging to identify that.
Yes. Well, now it's turning into a very interesting technical discussion, and that was actually what was intended. You will have the word just in a second, because I would actually like to say it was a very aggressive bench testing technique, but it was actually made to see if a new modality would help identifying a complication. So it was not to show how we actually perform the complication. It was the 3D technique to identify if it happens. And that is actually extremely interesting, because we know from the October trial and some of the sub-studies that even in trained centers with trained operators using intravascular imaging, OCT or IVUS, a huge amount of those operators was not able to recognize the mishaps during the procedure, so they just overlooked them, and it translated into late results. So this new technique is actually maybe an easy way to identify that there's a problem that needs to be corrected.
Can I ask one question, please? Yeah. So, Dr. Burzotta, in your beautiful bench study, in the POC, we achieved area of almost 25 millimeter square. So that would actually mean a diameter of almost 6 millimeter. And the stent platform, I know that can stretch. So do you think that if we stretch the stent up to 6 millimeter in the distal left main, it will cause any stent fracture or polymer damage or anything like that?
So I think that one of the parameters that we did not study enough is the fact that at the polygon confluence, when we dilate the main vessel stent, we reach into where there is the scaffolding of the branches, a bigger expansion of the stent. This is why even if there are many platforms able to reach, for example, 5.0, it is really advisable, if we are overstenting the bifurcation, to have a stent platform that allows to have this bigger expansion. For Altimaster, the one Nagomi that we had, there is the possibility to reach 6.0. So it is still something that is on label, but we know that for other platforms, it is even impossible to reach this amount. So polygonal confluence requires, in the case we balloon the side branches, bigger than nominal left main diameters for the stent.
Thank you very much. So we will just move on to some more comments from the panel.
Yeah, if we're coming back to Francesco's fantastic presentation, and we all know that Gabor taught and his team has always been known of very good bench testing, and I think this is a fantastic case and fantastic presentation. Now, coming back to the practical issue, that sometimes you have to understand that if you want to do tracing, then you need 8 French. And sometimes you don't get started with 8 French. And so did you consider just at least applying sequential kissing for this possible bench testing and for the apposition and micro-CT? Because that would also be a good idea if you don't want to start with 8 French guide, because sometimes it just happens that you...
Yes, so the question is well taken. We thought that it was really time to compare the two techniques, sequential kissing and tracing, because they are the two main options we have in the case we want to dilate the side branches in the case of trifurcations. First of all, trifurcation is compatible also with the 7 French. This is important, okay? It is compatible, not for all sizes of branches, not for all the materials, for example, non-compliance, but to know this in advance is important. So tracing is not a matter of 8 French, it is 7 French compatible. We are routinely doing by transradial approach. But it's true that sometimes you want, you didn't recognize that the trifurcation was so important. So it was important to have this bench test showing that sequential kissing translates into a final appearance of provisional that is very similar to tracing, except for a little bit more, less expansion in the polygon of confluence, and we do not know if it is clinically meaningful. So I think that we have two different ways to deal with that, and it is a matter of selection by the operator.
We have a question from the, just behind you, Francesco.
Okay, one question for Dr. Burzotta. It's a very practical question. I use a 7 French to do the tracing, but it fits 2 NC balloon and 1 semi-compliant balloon, and it's always a Terumo one. I think is the only way, because I tried with a 3 MC and there was absolutely no room.
Yes, so the concept of 3 non-compliant balloon is really challenging. Most of the time we use a semi-compliance balloon, but the take-home message for that is if you want to embark in tracing, you should know your material and the one you have in your cath lab and the compatibility on advance. It is really, I mean, disappointing to embark in entrapped balloon somewhere into the guiding catheter. And let's remember that the sequential kissing done with LAD and ramus, LAD and circumflex was comparable in the bench test.
Thank you very much. Let's move on with some very quick comments from the panel.
I really enjoyed some of the simulation sessions here, and it's clear that we can see from some of the slides that we're really accurately capturing the macroscopic anatomy of coronary arteries, and we're improving our understanding from simulations there. I wonder, as cardiology is starting to acknowledge not just the macroscopic anatomy, but also the microvasculature, how that might influence the way that we do simulations. Some of the simulations we saw here, I wonder how the results might be different in a patient with microvascular dysfunction, maybe 20, 30% less flow in that coronary artery.
Well, maybe you have a comment on that, Tinen, from the simulation with the FFR and the microcirculation.
Well, that was a very excellent comment, and that is something that we're definitely either looking at for next steps, is how we can incorporate the microvasculature, and how we can simulate the microvasculature, and just even for other heart failure and other issues. So that was, yeah, excellent. I won't take more time.
I would like only very short comment because we are over the time, but I think this session was very important. I am thinking, how can we incorporate bench testing idea to our fellowship program for fellows? Because only then, seeing what happens in vessel, for example, with the stent, how we use it, where we put it exactly, it gives so much information that I think it should be an obligatory approach to making our fellowships.
It's an excellent comment. We can see how happy Francesco's fellows were in the picture he showed us, right?
Yeah.
A last comment?
Yep. Yeah, actually, the bench test is very interesting and important for us because so the bench test result and the real clinical outcome is supportive relationship each other. But when I always perform the bench test, only one thing is we never forget that bench test is bench test. That is not a real clinical field. So I always never forget about that. That is a very important thing, I think.
Well, that was actually an excellent comment to finalize the session, because what we are working with is translational information. Something from bench, something from clinic, something from epidemiology, but we can put all the bricks together in a translational way. So thank you very much for participating in the panel and for participating in the session and for giving the talks that actually made such a great discussion that will bring some of the ideas in the club forward. Thank you very much. And there will be a coffee break outside.